Greetings, my name is Sandy Herek. I am going to share with you something about sensorimotor psychotherapy. I'm with Liberty University taking course 715 with Professor Warren. Sensorimotor psychotherapy is a body-mind approach to treat trauma and attachment. Here we have a picture of its creator, Dr. Pat Ogden. We're going to cover what is sensorimotor psychotherapy, where did it come from, what is the central construct, what according to the theory creates the dysfunction, how it creates change for recovery and healing, very important, and also very important, Christian applications and references if you want to look into it further. Unresolved trauma, attachment disorders, relational difficulties, and the role of the body in sustaining such difficulties in what often becomes an endless feedback loop or vicious cycles and patterns of negative interpersonal dynamics are the central focus of sensorimotor psychotherapy. Dr. Pat Ogden spearheaded the development of sensorimotor psychotherapy. As all good stories do, Dr. Ogden's vision for psychotherapy was born in a yoga mat. While serving as a yoga instructor and technician at a psychiatry hospital in the 1970s, she noticed the relationship between a person's body and their mind, particularly noticing something amiss, a disconnect of sorts between the mind and the body. Nonetheless, she was aware of how individuals would respond to triggers, often reliving the trauma, not just in memory or emotionality, but with their bodies as well. Soon, she was in collaboration with psychologist Ron Kurtz, who had developed a body therapy called the Hakomi Method. The Hakomi Method is a mixture of Buddhism, Taoism, among other Eastern philosophies, practices, and Western psychotherapy. After working and collaborating as the Hakomi Institute's co-founder, in 1981 she branched out and established the Sensorimotor Psychotherapy Institute. The Sensorimotor Psychotherapy Institute is a training organization that teaches the principles of sensorimotor psychotherapeutic body-mind approach. Sensorimotor psychotherapy combines somatic therapies, attachment theories, cognitive applications, neuroscience, and techniques from the Hakomi Method. You can learn more on goodtherapy.org. Among other influences and collaborations are the name of Claire Payne, Janina Fisher, Ruth Linnaeus, Alan Shore, Bessel van de Kolk, Onno van der Hart, and Elliot Nijenhuis. Sorry about the pronunciation. Again, this can be found on goodtherapy.org. What causes dysfunction in the theory's view? In a nutshell, sensorimotor psychotherapy uses the language of the body per se as the vehicle for understanding human behavior and as the target of therapeutic action. Ogden and Fisher, 2015. The general concept is that whether due to trauma or attachment injury, there is some sort of action or experience that went unfulfilled. Think of a rape victim trying to fight the assailant, or a soldier unable to unseen the horror spreading across the battlefield, or the adult who never got the nurturing required to develop a healthy sense of safety in relationships. In all these examples, there's a physicality, a component of the experience that the body was part and parcel of. Ogden and Fisher, 2015, state that the experiences, without the ability to be reflected and revised, create dysfunction. Moving forward, we're going to see what is the nature of the therapy model, the role of assessment, and the assessment based on the sensorimotor psychotherapy approach, which has 3 phases. I have put this under the headed of how it creates change for recovery and healing, because understanding these 3 components is important to the implementation of the model if you're doing it with the intention of creating a space for recovery and healing, of course. The theoretical models informing sensorimotor psychotherapy guide the therapist to look for indicators connected to attachment interactions and unresolved trauma. Macero, 2017. Sensorimotor psychotherapy is experiential. The experience consists of assisting the client in re-experiencing the traumatic event in a safe environment, but they're guided in completing any unfulfilled actions through the body. In other words, this is the corrective experience. In order to experience completion and experience the final closure, this is needed for recovery and healing. The role of the assessment. Before we discuss this, it is important that we differentiate two broad categories of assessments. One category, for the purposes of this presentation, will be called intake assessment category. The second category is going to be the theory, model, intervention specific assessment. The intake assessment is the first category, is what we need to complete in order to diagnose, to examine the symptoms, their frequency and intensity, estimate the level of dysfunction across dimensions, social and occupational impairments, and associated needs such as referrals, crisis planning, and perhaps, if we have time, a cultural formulation. The second category is associated with the approach, the modality, and what it aims to accomplish in terms of process to reduce the symptoms, frequency and intensity, increase functionality, and improve social and occupational development and growth. That said, the assessment, based on the sensorimotor psychotherapy approach, process-based, has three phases, each with specific goals and objectives of their own. The first phase is where the therapist assesses and identifies the physical and mental connections which are blocked or frozen. The goal will look something like this. The client wants to identify and develop their resources for symptom reduction and stabilization. Then we have a series of 6 tasks. The client wants to identify survival resources to help them cope with adverse experiences, wants to assess, acknowledge, and develop their strengths, talents, and competencies. The client wants to recognize triggers and signs of excessive or dysregulated arousal, wants to develop and use new resources to regulate arousal and increase competency. The client wants to increase awareness of how posture, movement, and gestures affect arousal and well-being. And the client wants to change traumatic, distressing, or unsatisfying orienting habits. This was modified from Ogden and Fisher, 2015. Phase 2 is where the therapist assesses and identify where these incomplete defensive responses could be brought to resolution. These are entry points for change, right? So the goal will look something like this. The client wants to address traumatic memories, processing traumatic memories, and maintaining symptom reduction and stabilization. The task would look something like this. The client wants to recognize signs of implicit body triggers, memories in their current life. The client wants to identify, embody, and practice resources to cope with the effects of distressful memories. The client wants to discover resources used in painful events of the past. The client wants to maintain dual awareness to address state-specific memories without reliving the past. Wants to explore the effects of memories, sensations, sensory intrusions, emotions, movement, thoughts. Wants to practice empowering actions that they couldn't use in the past. And the client wants to address dysregulation, arousal, and emotions related to animal defenses, basically the fight or flight. On phase 3, The therapist will assess to identify what mental practices, physical exercises, and mindful self-awareness are a good fit for the client to provide sustainment of the gains. The goal will sound something like this. The client wants to move forward with body-mind healthily integrated. Reintegration of body-mind to maintain gains in symptoms reduction and stabilization. Objectives and tasks. The client wants to address the legacy of their relationship history, including early attachment. And the client wants to discover limiting beliefs and how they affect their body. The assessments are an ongoing process. The assessment for sensorimotor psychotherapy is not an isolated event. It doesn't happen just once, as the intake assessment might, unless there's updates or reviews or revision or a new event takes place. Assessment in sensorimotor psychotherapy is an ongoing process and part of the therapist's task. These assessments are called body scans, observations, etc., where the therapist's ability to be present is demanding and determinate. It is through the observation that the therapist can take note and illuminate perhaps the most subtle of the body's clues that are in need of reflecting and revision. The therapist may be direct or indirect in their redirection of attention to the somatic expression associated with trauma in terms of communication. For instance, the individual who may not like to be told what to do may need to be redirected indirectly. For example, you may want to notice if your shoulders are feeling heavy and roll forward. Or if the client needs to be told things or else they cannot act, the therapist might say, I notice a heaviness in your shoulders and forward roll position. Can you notice it too? Either one, based on the therapist's awareness of how the individual communication style may be, can be used. The point is that both the therapist and the client need to partake actively in the intervention at these times. The transit of the information back and forth between client and therapist and client is ongoing through the session. This includes verbal and body communication or implicit communication. And as with most therapists, the client's characteristic will include motivation, readiness, and open-mindedness. If we have this, the therapy is off to a good start. And while the purpose of therapy is to help the client become more tolerant of these stressful states, so they do not impair their functionality and activities of daily living and social components of their life, if the client has a good window of tolerance or is willing to develop one through therapy, then success rate is even improved. If there is a characteristic that the client must possess, however, is tolerance for safety reasons. And if they do not have it, this means that more time in phase one is indicated in order to strengthen areas of weakness impacting their ability to withstand the re-experiencing of traumatic memories. In other words, enlarge the window of tolerance in order to create, or as part of creating, a safe space. Now I'm going to share a few techniques for each phase. I'm going to name the goal and the objective that the technique is addressing. For example, goal 1, where the client wants to identify and develop their resources. The objective 1.1 will be the client wants to identify survival resources that help them cope with adverse experience. A worksheet that can be found on Ogden and Fisher 2015 suggests a cluster technique with the words possible survival resources, as you can see here in the middle. Here, the therapist prompts the client into listing both positive and negative, also called creative and survival, ways the client has coped in the past, and what they may have used. Anything and everything counts, from walking to disassociation and everything that could be in between. Meantime, the therapist is body scanning and taking notes in such body clues for use later in therapy. What happens next is that the therapy takes the resources and reframe them. First of all, they will be asking the therapist to pair up, I'm going back, a couple of these techniques, a positive one or creative one with a survival one or a negative one. Notice take a walk as the positive, creative one, and isolate or withdraw as the negative or survival one. The therapist will ask the client, what are you still using? And for each one of them, we'll invite the client to explore if they're useful or if they might be hindering their life across different dimensions. And like I said, they will match survival and creative ones. In other words, negative and positive ones. For example, isolate with taking a walk. And how does your survival resources affect your arousal and body is another way to reframe or start reframing these resources for the client. Through phase 2, where the goal is the client wants to address traumatic memories, whether from trauma, physical, emotional, or both, or attachment injuries, or relational distress, or negative and impactful negative experiences, okay? On objective 2.5, the client wants to explore the effects of the memories, the sensations, the sensory intrusions, the emotions, the movement, the thoughts. The intervention would likely consist of the therapist prompting the client to select a painful memory to work with, albeit at the beginning, perhaps not the most painful memory. After all, we want to use this as well to continue building their window of tolerance. This will be followed by the therapist asking the client to focus on any positive experiences that were occurring before the distressful event. This could be anything: sensations, sensory intrusions, positive ones, emotions, movement, or thoughts. Let's say that the negative experience was being held at gunpoint. But before being held at gunpoint, I had a sensory intrusion of the wonderful smells of some gardenia flowers that I was walking by, and I felt the air in my skin, and I was feeling light and happy. I was moving swiftly, and I was thinking of nothing but seeing my daughter. That was before, and these are the positive sensations. The therapist would then ask about movement or sensations as the client is embodying that positive experience, which is what I already shared with you. How the tension on the muscles change, same for the breathing and any other observations that the client may be able to recall at this time. Then this is followed by the therapist asking about good thoughts or emotions to go along with these positive elements, as many resources as we can. Finally, the therapist will gently redirect the client towards the painful memory again, while using these resources and to take notice of how different the client experiences the event of recalling when paired with all those positive elements and resources accounted for earlier. In contrast, when the client is remembering being held at gunpoint alone by itself without those positive thoughts, memories, sensations, movements, anything. And then they reflect on that and revise it. The same line of prompting to evoke positive aspects of the event during the distressful event It could look something like that. While I was being held at gunpoint, I did think about my daughter, and I was just thinking about her. And while I was frightened, I was hanging on to hope that I would see her again. And that hope was beautiful. Finally, the same line of prompting to evoke the positive aspect of the event after the distressful event, and the same comparison takes place. After the event, he took my purse, and I was feeling hopeless. But would you please remember anything positive? Yes, I was remembering being glad to be alive and that I could see my daughter. And I smelled the gardenias again. At this point, the therapist would again gently ask the client to remember the event, taking into account all those positive resources from before, during, and after the significant negative event. The work from these 3 exercises above are consolidated in one activity where the client links the positive elements to resources that they can develop and call upon when triggered. So they start organizing their assets. What resources were interrupted or put aside due to the event that are explored as well. For instance, maybe there was the desire to want to run. That resource was not executed. The desire to just knock the gun out of the guy's hand. That resource was not utilized. It was interrupted. Please take note of that. This is an example of phase 3, goal 3. On goal 3, the client wants to move forward with body-mind healthily integrated. And in this objective, 3.2, the client wants to discover limiting beliefs and how they affect their body. So the intervention will consist of providing the client with 4 different body posture images and asking the client to imitate each posture. A list of possible experiences is provided for the client to evaluate if there is a match for them. Space is provided for them to add anything not covered on those choices. Each pose is finished with a question, such as, what childhood experience may have had contributed to this belief? Or, in the event of trauma, what experience may have had contributed to this belief? The thread that keeps the model cohesive throughout the different phases and tasks and the interventions for them is how the therapist and the client work together in developing the 5 building blocks of the present experience, the one that is being enacted in the treatment room. These building blocks, if you were to stack them from the bottom to the top, the first floor will be inner body sensation. The second will be movement. The third will be 5 sense perception. Then it will be stacked up by emotion, and on top of it all, cognition. Here is a few video examples of the techniques. Here's about tracking the body to heal trauma.
Ready to start eating healthier? Meet Chala. Chala is the world's healthiest.
After trauma, it's common for people to develop certain bodily responses without even realizing it. But by becoming aware of our body's patterns, we have an opportunity to develop new patterns that can result in dramatic changes. Dr. Pat Ogden explains how what she calls contact statements can encourage people to discover their body's response to trauma and find the meaning behind it. She refers to her patient, Bill, as an example of how this is done.
Another part of your work, you use something called contact statements. Can we talk about what contact statements are in your way of looking at them and how you use them, perhaps with this most recent person you talked about, or with Bill, the man you talked about just before that.
Okay, yes. Well, contact statements are something that I learned from Ron Kurtz, who was my primary mentor in the 70s. What's interesting about contact statements is that everybody makes a contact statement, because a contact statement is just demonstrating that you understand what a client's going through. So you might say, oh, childhood must have been so hard for you. That's a contact statement. The difference in this work gets back to working with the now. Therapists have to learn to make contact statements with present moment experience that incorporate the body's response. So with Bill, I might say something like, as you talk about all these losses, your head's starting to pull in more. That's a contact statement with present moment physical experience, which therapists are often hesitant to make because it's not a contact statement we would make in our daily lives. Contact statements are things that we make all the time with our friends. Oh, wow, you're having a great day. That's a contact statement, right? Because it shows you understand their experience. But when you start to bring in the body, it feels off to people. So that's where tracking comes in. You have to track the client's response. And if they have a aversive reaction, then you have to make contact with that. Oh, something disturbed you about that statement, huh?
And yet, when you're using a contact statement with in reference to the body, it sounds to me like you are not making an interpretation,
Right.
like as in your shoulders are hunched and that therefore means.
Right, no, you're right, because I want the client to discover what it means. So, and often we'll even put a qualifier. We might say, it looks like your shoulders are hunching up right now, and so then they can confirm or deny it. And then if they're interested in it, then we can explore it. Well, if you go into that pattern, what does it tell you? What do images come up? Do words come up?
And would you kind of have them almost exaggerate that pattern so that they can get really into it?
Exactly. Yeah, but just a little bit, just because you don't need much. It's like you raise the signal just a tiny bit. Just try it on just a tiny bit more, and the more subtle, almost the more potent it is for them.
Being able to pick up on body cues can be a key resource for healing.
If you have any.
Here's a second example of how we can use body posture in addressing limiting beliefs.
I worked with a young woman who was referred to me because she hadn't talked at school, and she was very, very withdrawn, and they'd had a suicide at her school, and they were really afraid that she would be the next suicide. She was only 13 years old. When she came to therapy with her mother, she held her head like this, really literally to one side, shoulders hunched, head held over. Her mother did all the talking. Her mother said that her daughter felt there was something wrong with her. The daughter didn't talk at all. As we started working as a body therapist, I knew I'd wanted her to go from here to here, right? But first we had to explore this, and so I asked her about it, and she did talk, and she said that she wasn't confident. And as she went into this, she brought up memories of being bullied, like over and over, for being fat, which she wasn't, being Latina, being stupid, which she wasn't. And those impacts had a great, great impact on her. So she brought up one memory in particular of being 8 years old and reading something in front of her class, and everybody laughed at her. And so we had to work with that 8-year-old. It was very interesting because it was almost like a child, a 13-year-old, working with an inner child and an 8-year-old. Yeah, and but we hadn't really addressed her posture, because first we needed to do that integration with that 8-year-old part, who was terrified to to show herself and to sit up tall and bring her head on straight. And the 8-year-old really questioned if she deserved respect. She didn't think that she deserved any respect. So, we worked with that, and this girl was weeping. It was, it was really touching. And then after that, we started to address her posture and shifting the way her body held that limiting belief. But as soon as she straightened up, she felt really anxious. And that was that part that had gotten bullied, that was so frightened, So we worked with her, bringing her head up, and she had felt the anxiety in her stomach. And then she just brought her hands gently to her stomach to connect with that part and soothe it. And then she felt comfortable, shifting the pattern that held the belief. But we couldn't override that 8-year-old. That 8-year-old had to be included. The 8-year-old was terrified. So she had to keep track of that anxiety that belonged to that 8-year-old and keep soothing it through the hands on the belly, keep protecting it that way as she practiced the new function.
Did that have any impact on her life at school?
She felt more confident. One of the things she said that was really touching was that she said she felt like dressing up. She felt like wearing nice clothes to school, like the popular girl, she said, like skinny jeans. And she'd always worn, like clothes that just covered herself up. So that was a really good sign.
Hi, my name is Susan, and I'm 6.
One last example. This is an explanation by Pat Ogden herself. When counter-transference, which is when the therapist transfers emotions to a person in therapy, usually in response to what happened to have been amiss, but nonetheless experienced by Dr. Ogden in therapy, of transference of the client, which is when the client transfers emotion to the therapist.
Let's talk about therapeutic enactments and two parallel simultaneous journeys that we are on when we're doing therapy. One journey is our explicit journey that we can describe, we can talk about, we think we know what we're doing as therapists in the therapy hour. But the other journey is an implicit journey. It's a body-to-body communication that is implicit. It's not conscious. Dan Siegel talks about in therapy, we're shaping the flow of information and energy towards more integrative functioning through the use of mindfulness and awareness, being aware of present moment. But what happens when we're not aware and when there's this body-to-body conversation going on that can often make the therapy feel stuck, confusing, frustrating, boring, and even frightening. Now, this is challenging for both therapist and client because this is the point where interactive negotiations of the past have failed, as Karl-Heinz Ruth says. They haven't been successful, and they're being reenacted in the therapy hour. One example from my own practice was working with a woman her mother was very invasive. And as we were talking, her body was getting tighter and tighter and tighter. And I was trying to elicit from her movement from her body, but her body just kept getting tighter. There was one moment where I leaned forward to work with her. And I think I asked her to open her eyes. She spontaneously closed her eyes, to open her eyes and look at me and see if that wouldn't mitigate the freezing. But she just got tighter. And when I pondered that session, I realized that we had a hand-in-glove fit from her childhood. My mother was rather withdrawn. She'd suffered some pretty severe losses when I was little. I think she was grieving, and I was always trying to reach my mother And my client's mother was very invasive and pushy, and she was trying to get away from her mother. So we got into the therapeutic enactment that we had to negotiate together. The point I really want to make is that these enactments are not errors, they are not mistakes, and they are not failures. I've come to see them as moments of intelligence of two people coming together in their mutual search for a higher degree of organization. So the really magical moments were negotiated well.
There's a large body of research on body-based interventions, along with the strength of evidence in effectiveness of modalities such as interpersonal neurobiology, trauma and attachment research, blending theories and techniques from cognitive, affective, and psychodynamic therapy with the somatic interventions, as we've seen, which inform largely a lot of the sensorimotor psychotherapy. For example, here is a study where 10 women with a history of childhood abuse participated in 20 weekly sessions of sensorimotor psychotherapy informed group therapy and were assessed at pre-treatment, post-treatment, and at 6 months follow-up. Participants demonstrated significant improvement in body awareness, disassociation, and receptivity to soothing. Langmuir, 2012. Another study showed using this sensorimotor psychotherapy group treatment, participants, which I have to say they were veterans experiencing PTSD post-war and having experiencing relational distress at home. The participants had the opportunity to increase their window of tolerance for somatic awareness and for relationship with others, according to Klassen et al. 2020. Yet, there are studies on the other side of the conversation. On this other side of the fence, the confidence in body-based approaches are challenged, such as Rosendahl et al. 2021, in where meta-analysis study shows that for psychological distress, included studies, which the included studies was body-based psychotherapy treatments. At least small advantage of the body psychotherapy was noted as compared to control group. There is a call to action in this article, but before I get into it, I just want to reiterate that this particular article, if you read it more, they made a big deal emphasizing the smallness of the advantage. And they're saying that further studies should take place with particular attention to high quality studies that include bigger samples, elucidate conditions for the effective use of this body psychotherapist, and emphasizing that those studies should report data on safety aspects, adverse events, acceptability, and patients' preferences, which is a big deal these days, especially on assessments. Now, because the approach is not interpretive, as you saw in the videos, there's not one definition of what one posture or gesture may mean. For example, when the therapist detects through the body scan a movement, a posture, a gesture, the therapist uses a non-directive approach, using either direct or indirect communication, depending on the style of the client, to explore its meaning, just as those contact statements from the videos. This will be very much, dare I say, person-centered. Person-centered allows for inclusivity of cultural, religious, and identity among other diverse lenses that an individual may have. In regards to the Christian worldview, where our bodies are the spirit's temple, it could be said that sensorimotor psychotherapy could allow the spirit to talk through our bodies. What Pat Ogden called in her video about the countertransference, in which she mentioned that her countertransference and the client's transference was a form of intelligence, could be interpreted as divine intelligence by the Christian worldview. Sensorimotor psychotherapy is biblically supported. For example, take this example from Mark, the book of Mark. Jesus finds a man that is possessed by a multitude of demons, who gives the collective name of Legion. Fearing that Jesus will drive them out of the world and into the abyss, this legion begs Jesus instead to send them into a herd of pigs, which Jesus does. The pigs then rush into the sea and are drowned. This is an example of how our sins, misfortunes, and negative energies do impact the body to such a degree that even pigs cannot take the physical pain it exerts. A Christian client and or a Christian therapist could find guidance also in the biblical example from Mark 8, chapter 8, in where it is said, "Once more Jesus put his hands on the man's eyes. Then his eyes were opened. His sight was restored, and he saw everything clearly." This could be engaged as a biblical encouragement that if we allow Jesus to put his hand on us through these sensorimotor interventions, we will receive his grace and heal. Further theological reflection related to this sensorimotor psychotherapy can be explored around customs of various churches, where depictions of Christ's passion are enacted either in the town street reenactments done by the townspeople, or the plays, the drama plays that are put forth by the congregation, usually by the children's church group or the youth group. Think about this collective practice of embodying Christ's passion or Christ's birth during the Christmas season. This is worth exploring in the context of spiritual healing and sensorimotor psychotherapy. Think about it. Through these reenactments or drama plays, the members collectively engage in the embodiment of our sins and fallen nature. The implication is that these practices of reenactments, just like Dr. Ogden calls them, reenactments, or drama plays, allow us individually and as a group to experience spiritual strength, hope, and healing by reflecting and revising the experience of our original sin and fallen nature, and experience the corrective experience of Christ's birth, death, and resurrection, which is at the center of these yearly traditions. From the references, my favorite was Ogden and Fisher, 2015. I encourage everybody to invest in this amazing textbook resource. It's filled with a variety of interventions and worksheets. It explains the model very thoroughly. And also check out the Sensorimotor Psychotherapy Institute. I hope you have enjoyed this presentation. Health and light, everyone.